So with that, I would really like to welcome everybody again to our May 2024 keynote webinar on the surgical treatment of pain. And today we're very fortunate to have Dr. Dominic Power as our moderator. Dr. Power is a hand and nerve surgeon within the National Health Services at Birmingham Hand Center and the West Midlands Brachial Plexus and Peripheral Nerve Injury Service, which he founded. Dr. Power treats complex civilian trauma as well as military personnel with combat injuries. He's led the development of multiple peripheral nerve specialties within the UK, has extensive publications on peripheral nerve care and repair, and we're very fortunate to have Dr. Power as our chair for the education committee as well as a board member. So with that, I will turn it over to Dr. Power.
Thank you, Stephen. First of all, I'd like to say a big thank you to Stephen for being at the helm of the GNF and driving education and research. We couldn't achieve what we're doing without your dedication and commitment. And also, before I start, a thank you to the subcommittee who specialise in setting up these webinars and for choosing such a thought-provoking topic. So today we're going to be talking about the surgical management of pain, which is one of those areas. It's the sort of black box of nerve surgery where we have real challenges with our patients in the clinic. And so it's incredible that we've been able to bring in, through her very busy schedule, Professor Amy Moore, who needs very little introduction. So Amy is a professor and chief of plastic and reconstructive surgery at Ohio State University. She is based in the Wexner Medical Center, and she is a proper surgeon scientist. So she brings innovation from the lab through to the clinic, and at the same time can focus and steer preclinical research based on the challenges that she faces in the clinic. I've known Amy for many years and followed her career in awe. She's a brilliant educator. She's a brilliant researcher. She is great to answer complex questions and distill it down into a very understandable subject matter. And really, she needs no further introduction. So I'm going to pass over to Amy and ask Amy to give her talk. If you have questions, put them into the Q&A box, and then I'll try and curate them, and then we'll have a question and answer session at the end. So over to you, Amy, and thank you for your time.
Okay, are you seeing my slides?
Yes, that's fine.
Okay, so and then do you see me, or you just see my slides? And then good morning, everybody, or good afternoon, or good evening.
We can see both at the moment.
Okay, all right, but you don't see my background. This is the only problem I have. It doesn't turn green, but okay, we're gonna go with this. Okay, well, good morning, good afternoon, and good evening. And thank you for the kind introduction. And Stephen, I echo the gratitude for all that you've put in to make nerve matter on a global standing. And to those who are attending, thank you for being here. I see multiple friends who are listed. Today may be a little bit different than the type of talks that you are used to hearing. I have really no disclosures that are relevant to it, but I do want to acknowledge that I have permission from my patients to share their story. And then I want to thank Susan McKinnon, one of my mentors, who told me early on if I wanted to be a nerve surgeon, I needed to treat pain. And I think that is a critical transition in my practice. So where I wasn't afraid of treating patients who had nerve injury and pain, and moving more towards seeing now a lot of patients who have pain and then figuring out the back way of what is the nerve injury. So I use this quote because not that it's that relevant, but I think it makes a point that people only see what they are prepared to see. If you look for what is good and what you can be grateful for, you will find it everywhere. If you look for your origin of your patient's pain, you will maybe find it. And so I think if anybody from this today joining us take anything away, I think it's oftentimes we don't ask our patients the questions that may help them the most. And trying to today maybe make that claim for you all, that we just need to ask. So my practice currently is 100% peripheral nerve. It is a privilege to be there. I refer to myself as a revision surgeon because often that is the patients that I get or that I have the opportunity to care for, in addition to acute nerve injuries. But I have really leaned into those patients with neuropathic pain and trying to really improve their quality of life. A Hail Mary referral for US football, it's a long, typically unsuccessful pass made in a desperate attempt to score late in the game. And I feel like that's my referral pattern right now, is these patients who've seen 10, 12 or more providers, who've had multiple operations and still are in debilitating pain. And so it is what I would say a privilege to be able to try to help these patients. And I'm just going to share with you more of my algorithm and key points to help treat these patients. Most of my patients come from orthopedic surgery. If you want to build a nerve practice quickly, become really great friends with your orthopedic surgeons. These are the physicians who are seeing the patients, the injuries. They are also ones that, if you align with them, we can do great work for our patients. This is a typical email that I get. I get these emails maybe on a weekly basis, but this one is definitely coming from a very prominent friend and nerve and hand surgeon. But I have a difficult patient, has been, with thoracic outlet, has had symptomatic neuromas, seeing other people, not very happy. She is diagnosed with documented CRPS. She would love a second opinion. She's kind of a disaster. I will tell you, in the US, we shouldn't write that because it's all discoverable. But in the end, it's like, okay, yes, let me help you. And that's what I say. I'm grateful I say yes. So when we're thinking about pain, and then I talk to my patients, I talk about brain pain and peripheral pain. And if we don't treat the brain pain, we are not going to be able to only help with the mechanical pain and then the depression. So brain pain is highly complex. I honestly, I don't remember any of that. I just put the slide up to make sense of it, but I don't actually know any of these pathways of pain really, nor should you. But the whole point is that it's very complex, and patients who have been sitting with pain for a long time, we need to, think about, okay, what is like their brain's been seeing, and it's been changing. We know that. And so I talk about needing to treat them with neuromodulators. We're going to treat the brain before we can treat the peripheral to best take care of you. And unfortunately, we don't know how to predict this kind of pain in patients. I do not believe in centralized pain, that I've seen many of patients who've had 10 plus years of pain, and a surgical intervention can improve them. It may take longer for them to get that relief. And it may not be, and most likely will not be, complete relief. But I do think that we need to stop saying, oh, you've had it for so long, there's nothing we can do. Mechanical pain is really what, as the surgeons, we can address. This is our field, right? This is, if we look for it, can we find it? And the double crush syndrome, like this from 1973, this paper let us know that if you have something more proximal, cervical disc disease, if you have diabetes, if you compress proximally, you are more likely to have compression distally. And this double crush is sort of the basis of what I'm doing when I'm releasing multiple entrapment points after trauma. And so the mechanical pain is what we can address. The brain pain is what sometimes you just need a psychologist, or you need a good pain management physician. But I am that person now. And so we have to address both. When we think of chronic compression, and this can be in addition to, an acute injury, a chronic compression, I talk about it that after a nerve is injured, it swells. We know this. This is done on animal models and in humans, that the nerve is swollen after it is injured. So now you have this proximal injury, the nerve is swollen, the nerve swollen is going through a fixed space, and it's the size of this nerve going through that space. And so the pathophysiology, what's been borne out through, carpal tunnel has been basically the standpoint of what we know most about compression neuropathy over time, is that the longer it is compressed, the more severe the symptoms can be, and it is progressive, correct? It's progressive. So when I think about it, you have these 4 lanes on a highway, and my fellows and residents, I think they like roll their eyes every time they hear me talk to a patient, but my patients get it, and they start talking to me about the lanes on a highway. So if we think of a nerve as 4 lanes on a highway, and in a nerve, and there's either construction or in a road, when there's construction or a traffic accident, all of the traffic backs up, right? And so that's the sort of the same thing as when we're thinking about the lanes of a nerve, is that as the lanes go down, because the swollen nerve is trying to get through its fixed space, we get pain. We get numbness, tingling, persistent pain, numbness, and tingling, and then weakness. And that is where, as all I'm going to do as the surgeon is one, I'm going to try to find it and provoke that same similar pain, and then I'm going to release the entrapment point. And releasing that entrapment point allows the nerve to expand back into its space, the lanes open up, and we can improve the function. So the last part of pain is thinking about depression. There is a complete correlation in multiple studies that show those who have depression have a higher prevalence of chronic neuropathic pain, and those who are being treated for chronic neuropathic pain are going to be more likely to be depressed. And so seeing and treating and not being afraid to ask your patient, hey, are you being treated for depression? Because if not, I have a great medication called Cymbalta or duloxetine, because that can treat both, right? And so we have options, and not being afraid to ask the question. I understand there's cultural differences across the world about patients' relationships with pain. And there are also their relationships with talking about depression. But I will tell you, I'm not afraid of this conversation. And if we don't address it, especially the young men with brachial plexus injuries, right? If we're not addressing that they have a huge life-changing event, that they are going to, over their 18 months of recovery, even though it's more than 18 months, but really over 18 months is when we see the major changes, they are going to have episodes of depression that we need to, as their provider, to help address. I had a lot of resistance early on about treating patients' pain with surgery. Our neurologists, our PMR physicians, the physiatrists, they all were worried that if we treat pain with surgery, we're going to create more pain. So we looked at the neuromas treated and looked at the softer side of what could be, and found that as we addressed patients who were indicated for a surgical indication of pain, we were able to improve their quality of life. We were able to improve their evidence of depression, and in the end, their pain also improved. So how do we do this? We're going to do this by a careful history. We're going to ask the question. So every one of my patients gets a pain questionnaire at every visit. It doesn't matter if they're there for an amputation, or if they're there because they had a nerve injury, or if they're there because they were told to come to me because I'm a hand surgeon and they have thumb arthritis. It doesn't matter. They're going to fill out this diagram for me. It's the first thing I talk about with my patients. I introduce myself and I say, hey, let me see your pain questionnaire. This is where we're going to start from, because if a patient's in pain and you offer them surgery and you haven't addressed the pain, they're not going to use their limb, right? So the idea is have an idea of what type of pain your patients are experiencing, and then you can figure out, okay, can I help them? And every time we see more simple and complex, and Susan has shown this, that someone will say they're coming in for carpal tunnel, but if they have this type of pain, we're recognizing that we probably need to look a little more proximal as the source instead of distally at the wrist. And often my revision surgeries are coming to me as, oh, I did a carpal tunnel, I revised it twice, and they still have an arm pain. Well, okay, well, they're probably internally rotated because they've been in pain. Now they've closed down their pec minors too tight, their lower traps are stretched out, and all of a sudden we have this muscle imbalance pressing against their plexus and causing pain. And so I really think it's important to make the diagnosis. Medications. Do not be afraid to prescribe medications. And so we looked in my early on when I got to Ohio State from St. Louis, when I was at Washington University, and I transitioned to a new hospital system and a new referral pattern. And I was surprised that no one was being treated with medications. And you can see here that the majority did not have any kind of pharmacologic support for their pain. And many of them were all over the place, right? So I think that this was just helpful for me to understand what the referral patterns and treatment of pain here were in Ohio. So let's talk about the diagnosis of revision surgery. Is it persistent? Is it recurrent? Or is it new? And Susan McKinnon has published on this in over decades, and I refer you to these two publications because it's spelled out so nicely. But I think in the end, we've got to distinguish between these three entities when we are getting patients who are previously operated, who have continued pain or dysfunction, and they're in your office asking for your help. We have to decide, is it persistent, recurrent, or new? So a patient who has persistent pain, it means that they went to the operating room and their symptoms didn't change. So when that happens, we've got to be thinking, okay, well, did I miss the diagnosis? Should I have been looking more proximal? Did I not release completely? Or is it just that it's going to take more time because I did a really great operation? Well, we always think that we did, but we did a really great operation, but it's just been that they had a decade of pain. And we just need to get them through that. For carpal tunnel, there is persistent symptoms up to 20% of the cases, and higher for that for cubital tunnel. When we think of this double crush, this can absolutely be why we still have that persistent pain, because of that vulnerable to compression distally. We release the distal, but the proximal there is still revving up and giving you that pain signal. When we think about persistent, we got to go back to it. When we think about the wrong diagnosis, the ulnar and median nerve are affected. We know this. Distal entrapments, these are some of the that can be there. When is it recurrent? All right, so now from persistent to recurrent. Recurrent is that they had a period of time when they had relief. And sometimes it's a couple of weeks, oftentimes it's a couple of months, but they get through this initial healing, they get better, and then they return. And oftentimes the majority of this is because of scarring. There is, goes back to that you can have this epineurial scarring, you can have traction, you weren't getting them gliding early enough. Recurrence is also just a part of the pathophysiology that can happen when, you have the decompression. But I often think like, okay, I don't want recurrent to be my first gun. I want to be thinking about all other possible sources. And new. So they came in with numbness and tingling, and now they have dense numbness in the third web space. Treated that patient last week. So the symptoms are different. The symptoms are different. And this is where you can't put your head in the sand. We say that in the US. You can't not address the patient's new complaint. Do not be afraid that you might have injured it. You might have injured it, and be aware. And don't be afraid of addressing that with your patient. You've got to lean into them and not ignore them. In the US, we're very litigious, right? There's a lawsuit coming on every corner. But that is still not the reason to not address your pain. We know that there's been studies that show if you lean in to your patients with those with complications, they will be better. So iatrogenic injuries are not unheard of. The physical exam, I'm going to speed through. This hand when you see it, it's awful. It's after a carpal tunnel. Well, that looks like CRPS to me. But what are the areas of compression that may not have a an imaging or a nerve study that can show it. And these are the median nerve in the forearm, the radial tunnel, and the pectoralis minor. I think pec minor is an unrecognized or an under-recognized compression point where the pec minor is so tight. Again, that pulls forward. They've been in this position of pain. Their posture is awful. And then they've stretched out their lower back muscles so that you have this imbalance. So here's where, the pec minor attaches, it pulls it in, these patients sit there, or it's the weightlifter. Oh my gosh, the weightlifter who have these like big shoulders because they've been doing all these shrugs and they're like, I don't know why my hands numb and tingling when I raise them. Well, I know, because you've been forcing that upper trap, you've stretched out the lower trap, and this pec minor has pulled on it, compressing against underneath your neurovascular bundle. Complex regional pain syndrome. I mean, we know this when we see it. I think it's important that you don't run from it. Usually there is a reason for it. And I think the idea of giving it time, I like stellate ganglion blocks. I go and release nerves quickly. I have not found that to cause more pain. Oftentimes there is a nerve that's been entrapped that has led to this. Thoracic outlet, man, thoracic outlet is a diagnosis of exclusion. And everybody gets sent to me with that diagnosis. Oh, thoracic outlet, they need to be addressed. I will tell you, it's very often I will find a nerve that's compressed that is giving these symptoms that has nothing to do with the neck, the scalenes, or thoracic outlet. Most of thoracic outlet is neurogenic. A lot of it, you have to worry about people's posture. I talk about posture. I talk about sleep. I give them, their awareness, and I put them in position. And this is where you have, oh, but it feels so weird. Well, maybe it does. But this is something where most patients have muscle imbalance, much more so than a physical finding. So again, you're going to look at their pain diagram. You're going to understand that when their arms are overhead, they're going to have that numbness and tingling. That's from that compression. Vascular TOS, you don't want to miss, but it has more vascular changes. So the coolness and pallor, the changing in pulse up and down, like literally, I do this every time. And all the time, I think I'm just feeling my own pulse. So I get the studies. I let them get the studies of the different ultrasounds at different positions. We'll do sometimes even more like angiography as needed to see if there's compression. So here's our exam. We're going to do it, but really you're going to focus on their posture because most of the time there's the posture there. So with this patient, you can see you're going to watch this shoulder here. He's going up and down, thumbs are up, and you're going to see he pops out sooner. So this is where he's muscularly imbalanced. You can see I've already released his ulnar nerve, and he's going to go up again. This guy loves being at the gym. He loves his upper, shrugs. And he comes and he's going to pop out again a little bit sooner. And so all we did with him was work on his tightening of his lower traps, avoid the upper trap, and then releasing the pec minor. So what can we use to help us? We can use the nerve conduction studies, but most of the time they're going to be normal. Most of the time, normal, so very unhelpful. If they're not normal, well, then that's good, because then you've just reaffirmed what your exam has shown. I love ultrasound. Ultrasound is, I have paired up with a really great physiatrist who does dynamic ultrasounds, which has helped because he's very good and thorough and spends the time with the patient and can help me confirm what I was suspicious of or not. Looking for tumors, looking for things I don't want to miss. But the perioperative care in the last, we're only about 5 to 10 more minutes, I promise. We're getting through it, and then I'm going to take all these questions and hoping that Dom can help a little illustrate that. But the perioperative care matters. So let's go through these a little bit. All of my patients, never say ever, always, never say never, but all of my patients are asked to see our hand or physical therapist. A minimum of 6 weeks. We have, again, I've built a big team. I have shoulder fellowship trained PTs who work with TOS. We meet on a quarterly basis. We talk about all of our patients. I have learned so much from them, but also your patient has to be committed to this. Most of the patients show up, oh, I've done therapy for years. I know what to do. I have those exercises. I don't want to spend more time. And I will reaffirm that in my practice, in my hands, I am not going to offer surgery unless I have worked with my team at least once, and they have assessed independent of me that there is a problem. So this is what we were talking about, the muscles. I have found many patients to avoid surgery. I personally have done these exercises and have not had anyone touch my ulnar nerve, despite feeling that that ulnar nerve is what was going down. And I got weak in the hands, and then I started doing this rebalancing. So I am a true believer. And I do think that it is important for your patients to be committed to the therapy before, so that afterwards, you know, they're going to get the best result by committing to it then. Neuromodulation. Do not be afraid of these drugs. These drugs, at the level of what we're going to prescribe them, are not scary. They're pretty safe. So here is my sort of algorithm for this. Everybody's going to be on a neuromodulator. Everybody is going to be, if they tolerate, many times they don't tolerate because they were started on too high of a dose. So we start low. And I think my next slide gives like where I start. But we start low. And if they don't tolerate the gabapentin or Lyrica, then I will use duloxetine or Cymbalta, which is an SNRI. And we are trying to help with the brain pain. I want their brain pain, as optimized as possible when I go to the operating room. Intraoperatively, we have I have no conflict of interest. It's called Zen Relief, and it has marcaine and meloxicam that are, it's like a honey that acts over 5 days. And I don't do the regional block until after the case. I don't like blocks being done by anyone else. I like doing them if I am there at the nerves. And every patient gets intravenous ketamine. Ketamine is an incredible drug for neuropathic pain. And there's been this big move to having ketamine clinics. I don't know if that's available where you are. It's all cash-based. And so I try not to, we will eventually, if someone's in a pain crisis, we will admit them and put them on a ketamine fusion. But it is not something that I'm advocating for the patients, but I do really like ketamine. Postoperatively, if they get into a pain crisis, which is rare, I mean, I've admitted 2 different patients in my 4 years. So this is pretty rare. We're seeing it in our military personnel who have more of the amputations or neuropathic pain from that standpoint. And then peripheral nerve stimulators are beyond me. Those go to our physiatrists and our neurosurgeons, and they work together to determine that. But those are my like last ditch Hail Marys to them. If I've done everything possible. So neuromodulation, here are the starting doses that I use. And it's slowly, and then they can tolerate it. There's other big drugs that are coming, the nortriptyline, baclofen, and buprenorphine. I don't prescribe them. Those are when I'm working with my pain specialist. But these top 4, absolutely anytime. Counseling, I have to, think about, your patients and what they need. Again, they're going to be going through something that they've either had 10 years of it. They've got to, there's this crutch that pain can be, but honestly, you have to treat the whole person. I don't want to be the counselor. Oftentimes, I think probably my fellows and residents thinks that I am, but I am not. And I make sure I address it and then move on. You need formalized counseling. We recently are getting ready to publish this, caregiver distress. And caregiver distress is a very common terminology in patients with terminal cancer or these more drastic diagnoses. But I would see my patients and the caregiver who's sitting with them, whether that be the mother, the spouse, the father, they're crying and my patient's just looking at me. And so what we were able to do is look at the patient and the caregivers, and we found that there was indeed incredible correlation between the patient's anxiety and that of the caregiver. And the distresses were high in comparison to the normal population. And so we need to be thinking of the next step, that you're treating not only the patient, but now you have this other side of the world that's their caregiver that also could probably be addressed in effort for us to get the best result in our patient, because they're driving each other. And so what we found, if you have your patient with anxiety and depression, there is no doubt that the caregiver is. And so now we're sending them both. And what they were finding in the cancer literature is that if you can educate both the patient and the caregiver, and they are on the same page of understanding of the treatment, there was improvement in this distress. So the key part is to set clear expectations with your patients who are presenting with pain. You're not going to be able to be predictive of who's going to get it, who's going to become it. We know that what we do has limitations. But honestly, you have to lean in and ask. You have to be aware that there are other factors that may be influencing your outcome, and pain is likely part of it. The other expectation is that if they are coming in at a 10, the literature will demonstrate that 3-point drop in the visual analog scale is improvement. And so I think if we keep all of this in mind, knowing that we are limited by just other factors outside of us, but we can have a positive influence. We can go into interventions. We can treat patients. This is a comparative meta-analysis that we have. We showed that in 77% of patients, no matter what we did, we could improve their pain. There's these novel treatments of neuroma, and this is beyond the topic for this talk, but there's ways to get the nerve, giving it something to do, somewhere to go, that can improve their pain. I showed that we can be releasing multiple nerves at the same time without fear of making them worse. It did not create any CRPS, and these are patients after trauma that we were able to release multiple places and improve their pain. Here's the last, we're going to finish on this case. This is a 31-year-old PhD student, very smart, had a history of pain for over a year, started during our COVID. He was playing the mandolin, and he was talking about it was all down his right side. He was depressed. He'd seen 12 providers. And these are all the providers he saw. He had $1 million workup. Everything was normal. On my exam, I could palpate, and there was just something thicker in comparison to side. You always start side to side, compare to the other side. He was tender at his pec minor. I was like, well, I can't lose him by going after his pec minor and going after his median nerve. And then I was going to take a look in his midbrachium. And this is what we found. It was actually pretty cool. We've found this other tendon biceps, and we were able to, and it's in one of these anomaly muscles, and we were able to excise it. Released, you can see, I did not go after his ulnar nerve after I found it, but I released pec minor and I released the median nerve in the forearm because of the tension that can be, and I think tension is a part of our nerve pain. And we found and took this little muscle out. And then here he was able to raise his arm, which he hadn't been able to do in years. And he was able to play the mandolin, which I actually thought would have a lot more movement, but he doesn't move his arm at all. But he's able to do it now without pain. And I think that the point of this is that I didn't ignore him. I believed him. Didn't matter. All of the imaging studies said there was nothing there, ultrasound included, but I took him to the operating room because he had nothing to lose, and we gave him back his quality of life. So in the end, lean in, make the diagnosis, and if you don't want to treat the patients with pain, refer them to somebody who will. And then aligned with your therapist, don't be afraid, prescribe the medications, and analyze your results. Thank you. And this is my email address. I encourage all of you to use it. I'm happy to talk nerve anytime. So I'm going to stop sharing, and yeah, let's have a conversation.
That's very brave, Amy. You're likely to get bombarded now with questions because these are really challenging patients.
They're challenging.
Thank you for a brilliant talk as always.
Oh,
It's such a big subject matter, isn't it? You know, when you get down into the nuances of the surgical decision making. But actually, this is a topic that's often overlooked, isn't it? How we approach these patients in the clinic, and there are no textbooks detailing how you approach and manage these patients. You learn yourself. You learn by listening to other people. And what's really interesting is that some of the things that you've suggested are things that we've learned the hard way in our own practice and have introduced, but there are many more things that you talked about that we could perhaps introduce. So the first thing I'm going to say as an introductory question is that last case has obviously been seen by multiple clinicians at multiple sites. How much pre-work do you do in terms of, once that referral comes, tracking down previous operation notes, records, therapy records, so that you can have a focused consultation with the patient?
So near zero. So I was wasting so much time early in my practice trying to understand everything of the patients who were coming. And all it did was put me on different trajectories. So now I meet the patient, I have them tell me what's going on, and then I tell them my homework is after we meet. Because I do think it matters what the imaging says and what the operative notes are, but I'm going to look at them after I meet the patient. And so I was finding myself biased to whatever the last note was. Oh, these people think this. And a lot of my patients see everybody across the country who is all these nerve specialists, way more gray hair than me. And I'm like respectful of that. And I just said, okay, well, all they're doing is jading my opinion. And so I don't waste my time early on. I put the time in after I've decided, okay, there's something here. And if I need to, I bring them back. And so it's not often, you know, or most of the time I'm sending them to the therapist anyway, at least for one visit. And then I bring them back to say, okay, now I know because you were hot everywhere, I need to bring it back. But I do not go diving into these charts as quickly as I used to, because it just became a bias, and it actually didn't help me decide what I needed to do for the patient.
Yeah, that's really, really helpful to hear. All too often I found that, you know, that operation note you're looking for where someone's made an assessment of an injured nerve, perhaps at the time of a fracture fixation, it doesn't shed much light on what was actually done.
Yeah, not when they're in your office complaining of the same pain, where you're like, well, okay, well, I'm still gonna go explore it no matter what that surgeon saw.
What about the personal touch? You know, I found sometimes ringing and speaking to a referrer, you get a little bit more information than may exist in the medical record, but it's very time consuming to do so. Is that something that you would do? Or could you talk me through how you would provide feedback to your referrers?
Yeah, well, the feedback's a little bit different than the pre conversation. I believe I built my practice because I talk to the referral physicians. I'm grateful. Most of the time I just say, thank you so much for thinking of me. I am happy to help you with this patient. This is going to be great. We're going to care for them. And then I ask, okay, well, when you were in there, what did you see? What do I need to be aware of? And in that conversation, I agree, is a lot of stuff that's not in the chart or the op. The harder conversation is after the fact. Sometimes things go well, I released everything, and they're like, I refer back to them after their first visit, and I'm like, okay, 2 weeks ago I did this and I found this. The harder part is when I find the injury. And that's what I found, even my case last week, which was a third web space. The surgeon, outside surgeon, said, oh, I explored it. It was just cut and scars. I didn't see an injury. And so, but the patient's miserable. So I go back in and there's this huge neuroma and it's all involving the third web space. And like the only reason it's there, I could peel everything else away, which was like total, here's second web space, thumb and thenar, and then here's this huge neuroma. And so that's the patient where, you know, I sent an email, I was like, hey, let's chat. And so I just made him aware. I was like, I found this big neuroma in continuity. I grafted it. I just wanted you to know, patient's happy, nothing's there. I just feel like that was there. And he was just shocked. But that conversation is hard. Not having the conversation, I think, would be worse though. Because in the end, he went back to the operating room to explore it. and then still said there was nothing. So I'm not sure. I just felt like it was important for me to give that feedback.
Yeah, thank you. I think it's essential, isn't it? I mean, we all have to reflect on our cases and learn. And if there is a learning point, then I myself would want to know.
Sure, me too.
One of the questions that I was going to pose was, you talked quite a lot about diagnostics.
Mm.
So you've got obviously access to MRI, ultrasound, and you mentioned about using ultrasound to exclude other pathologies such as a tumor. You know, because we've all done that, where you haven't imaged the nerve, you've gone in there and found an incidental, you know, schwannoma or something sitting at a compression point. So that's become, in my practice, a routine thing to do. But do you find ultrasound helpful in ascertaining whether there's a compression or a constriction around the nerve? Do you think it's useful in your practice? Do you do the ultrasound yourself?
Yeah, not yet. I want to. I feel like I could do it. I have funding. We just say that. I have funding to buy this high-powered ultrasound, and we haven't done it yet. Because I'm not sure the timing of when I would do it. My clinics are really full. It's more of my issue. So I have really leaned into this physiatrist who is able to, and he'll walk me through his images. But he spends the time with the dynamic, and so this has become essential for my TOS and PEC minor, is his ultrasound, because I know what he's doing and looking at it. And he will say, oh, it's not at the scaling. I see nothing at the scaling compression, but I definitely see it at PEC minor, or vice versa. And I think that's been very helpful. That plus my exam, and leaning on somebody objective, because I don't know. I mean, these patients are challenging.
Yeah.
I want to do it myself, but it's just figuring out how would I build that into the practice. Do you do this? Do you do it yourself?
I have used a local digital ultrasound that you can use through a mobile phone application, but again, the problem is in marrying that up as part of the hospital record, or whether you're using it as a diagnostic adjunct like a stethoscope. And so there are some sort of legal implications of how you use that, but I think it can be useful. But the resolution on those digital ultrasounds is often not the same for looking at the vesicular structure, but it could show you gross pathology. But I think we should use it more freely. But the problem in my practice is access to it, and there could be an 8-week turnaround to get the results back.
Yeah, and that is hard too. I mean, if I have something that's like, most of these are not time sensitive, to be honest. Like most of them, they've been having pains for years. So if they're going to wait 3 months to see this guy, they wait. And in the meantime, they're on their neuromodulator. I've added their therapy in. So like we're doing things to help get them to that spot before I operate. But I do think that ultrasound is probably my most important for any of the upper compression neuropathies, for sure.
Right. Well, there's already 2 or 3 other questions that this overlaps with, so you're not off the hook yet. Next question is about diagnostic blocks. Now, this is a controversial topic. You mentioned the use of local anesthetic blocks perioperatively or post-operatively to help manage pain. One of the questions was, could you just reiterate what the name of the long-acting local anesthetic is? Is it a liposomal local anesthetic?
It's you know what? I should Google it, because this is how I work, and everybody's gonna know now. I have no idea what's in it. I know what's in it, but I don't know what the name is. So it's called Zen Relief, and I have no conflict, right? I have nothing, but I use it, and it's changed my practice in the last year. ZYNRELEF, and it is bupivacaine and meloxicam. And it's an extended release solution. Look, I'm reading it off the internet. Okay, well, I can't read that because it's now the tiny print. But I will tell you, I haven't used any of the other liposomals. This one's like a honey, and it just elutes over time. That is how sophisticated I am about it. We should all read up about it.
I think
but it's amazing. It's changed my practice, because I'm no longer leaving a paintball catheter with Marcaine. I'm no longer asking somebody to go and give a block proximally, which I hate. I believe that the block injury to the nerves are so underreported. I have a whole series we're going to get out. I do not like blocks, but I will put them in under direct visualization. And this stuff has been a game changer.
That's great. Thank you.
Mhm.
Yeah, so the question was also about the role of diagnostic blocks in deciding,
Yeah.
is there a surgical target and what is the likely outcome? So my own take has been, perhaps if I'm expecting to find a neuroma in continuity, it could be helpful for the patient to understand what a resection and reconstruction of the nerve might look like if they were to remove that little bit of function. But what about in helping with decision making on a painful nerve? Do you find it particularly useful?
Um, well, that delay in humming there tells you probably that I'm not emphatically engaged in it, and I think it is a great topic. I will use it uh sometimes. I think I use it when patients, I don't have a clear understanding of, do they recognize what the pain is? Can I isolate it? I found that there's patients who've come to me who've already had blocks. It's like this field block, and I'm like, well, I don't know. Same thing with Botox. Like, I have one physiatrist who's now putting in like 300 to 900 units of Botox through the whole neck and shoulder, and they're like, yeah, they need a pec minor release. I'm like, dude, I'm not your technician, and I have no idea if you've just Botoxed everything. So where it is essential for me is, I love the idea of using it to have somebody recognize, okay, this is what it's going to feel like when your nerve is cut out. I haven't used red, but that's actually brilliant. I do use it up at the neck. Sometimes I'm trying to determine if it's pec minor, isolated, or at the neck scaling. And then that's where they'll do the diagnostic block separated by time to see if there's improvement of their pain. I think why I haven't used it so much is that I don't know that it correlates with my surgical outcome, and the expectations become a little bit marred. I
Okay.
don't know. What do you do?
Yeah, over the years, I've probably over-invested in blocks and then use them for the decision making. But the more you reflect and look at the practice, you realize that your gut instinct, I think, in the clinic is there's a surgically treatable lesion or not.
Correct.
I think that's more often
Yeah,
the
correct.
predict the outcome
Yeah.
in my own practice.
And maybe
Um,
people are saying hydrodissection. I don't know how that works either, except it's creating space, but like that's another part that I haven't leaned into. Do you do hydrodissection, and have you found it to be helpful?
no, not personally. No, I've read a little bit about it, but again, you sort of stick with what you know and what
Yeah,
tends to
I
be
know.
in your hands. And
Yeah.
the thing is, you mustn't be blinkered, I suppose, to innovation in the field.
It's
Um,
totally.
so yeah, but personally, I have no experience of it. I'm going to ask another question now that sort of comes back to that far lateral thoracic outlet at the pec minor sort of level. So we had a really nice question sort of saying, what are the typical symptoms? Which nerves tend to be involved? Is it the lateral cord? Is it the medial cord, median nerve? Could it be any of them?
I think for pec minor, it's more medial cord symptoms. So if they have their ulnar nerve, they've been advised multiple times, and I the first thing I do is come here. And what you're looking for is your coracoid, and then you just take one, like basically one finger breath in, and you push. And like all of us surgeons, we're gonna be tight there. But the pec minor, you find that, your coracoid, and then you just push one, centimeter down, centimeter over, and you push, and their eyes bright, like you watch their eyes, and that recreates this, like I'm doing right now, like I'm numb and tingling here. And so I think of it more of those type of symptoms. Everybody, and it's so non-specific, everybody goes numb and tingling with their arm up and abducted. Like, I mean, that's not going to be my distinguisher. This, nope, not going to help me. But if pain on palpation that responds to that, I find like that's very effective. I will do pretty commonly, not always, definitely not always, the pec minor with the median nerve in the forearm for that tension. Because I think the neural tension is what's problematic. In patients who can't do the nerve glides, I'm like, okay, well, we don't want to push past in pain and flare the nerve. And so I release the median nerve in the forearm with lacertus and the fascia between the two heads of the pronator. I don't release the tendon. But I think that combination of, if it's a tension, neural tension, that helps a lot of people with this horrible upper extremity pain.
And can I just ask technically, are you just lengthening pec minor? Are you fully releasing pec minor? Do you release the fascia
I do a
lateral?
tenotomy. I go up, I make a one small, like 2 inches, come down, split the pec from the deltoid, find the cephalic vein. Usually vessels go up, I go down, I find you're safe until you find the glistening of the tendon. I go around the tendon, both sides, make sure I'm not cutting the biceps tendon insertion, which I did one time, won't ever do that again. And I come across the tendon. And then once you free the tendon, the muscle retracts, make sure there's nothing laterally still attached. And then I free up, there's always a layer of fascia over the plexus. So I open up that fascia, put my finger up underneath the clavicle, make sure there's not a subclavius muscle tendon there, and then I'm done. So it almost feels like I'm cheating because it takes about 20 minutes. You know, it's simple, simple, simple. I don't know. It's I feel like, and then it works.
That's great, thank you. Well, we've only got a couple of minutes left, and I've got loads of questions. So, what I'll do a quick fire. Pregabalin versus gabapentin.
Pregabalin all the way. Pregabalin all the way.
Pregabalin all the way. And you mentioned for knowing success, you said meaningful reduction in VAS score of 3. Is that
I mean,
correlates with improved function generally?
It does per the pain literature. And I would say that I'm measuring their quality of life, and I'll see quality of life depression symptoms, and that will move more down the scale before the pain drops. So I'm seeing their quality of life improve, and then their pain drops. I mean, that's pretty consistent. They do this up and down until 3 months, and then 3 months they can climb to the improvement. When we were doing our study on amputees and TMR, we found that there was improvement in pain up to 18 months when we stopped checking. The biggest change was within the first 3 months, with it going worse, bad, worse, bad, worse, bad, stabilization at 3 months, and improvement to 18 when we stopped looking. So I do think that I'm looking at the whole picture, and most of the time they come in doing too much and then they flare. So we balance it.
Great, thank you. Another question was, does interruptive nerve stimulation become part of your routine in doing these multi-site releases, and can it predict whether a patient recovers or not?
No, it's not part of my algorithm. I am biased here. This is a conflict of interest because my study right now is looking at handheld stimulation and regenerative capacity. And I will, if they're weak in a nerve distribution, I will stimulate a nerve for 10 minutes because I truly believe in it because of the science that I did to support the study. But it is not part of I'm not stimming every nerve, telling to predict that it's going to recover. With compression neuropathy, if I'm doing it for pain, I am releasing, freeing it, and getting them moving within 24, 48 hours.
And a question which isn't answerable in 30 seconds, but the question is on stimulators. What happens when there's no surgical solution? Do you think there's a role for implantable stimulators? Do you do them yourself, or do you refer on?
I refer currently. I think I'd probably do a better job if I did it. In the sense of knowing exactly where the nerve is, and some of these ones are being implanted under ultrasound, and I'm just scared that they're going to hurt the nerve. So that's not giving a lot of support to those colleagues, but I haven't had any injuries, but I refer them. I have a neurosurgeon who does some of the spinal. I have a physiatrist who does the peripheral, and I just haven't had the time or the bandwidth to do it myself.
Thank you.
But I do think that when we have the patients, sorry, I'm gonna talk over you. I do think when the patients have had everything or I can't fix them, that is my next move.
Yeah. I'm just going to bring things to a close, but thank you so much for everything you've shared with us today. And we could have gone on talking easily for 2 hours on this topic. One thing I wanted to raise was, and perhaps you could just a parting comment on this, is it's clearly a problem shared, isn't it? You know, either shared with clinicians around the world. I've rung colleagues, asked for their advice. I work in an MDT setting and I can ask my surgical colleagues, but also you have to share the decision making sometimes with those wider specialists. But how, as someone who's set out to do nerve reconstruction, do you prevent your practice from becoming just nerve pain? Because it does take a toll on you as a clinician if all you're doing is dealing with complex patient, because amongst the real rewarding winners, there are other patients who perhaps can't be managed so successfully. Have you got any comments for how you would keep a balance in your practice?
It's currently unbalanced, completely unbalanced. But what it does is allow me, when I do have the acute nerve injuries that I can lean into quickly, they'll take priority over the nerve pain. And so the patients with nerve pain, they do consume you. They can, and that's why I always go to lunch in the middle of my clinic. Like there is an hour break and I take it no matter if I'm an hour behind. I'm taking at least 30 minutes to clear my brain, take a deep breath, come back to it, because I know these patients are not here in my clinic to like torture me. They're here in my clinic for me to help them. And so I try to maintain that positivity in that brain space. And so it's team lunch every time I'm in clinic. However, how do I balance like where it is? My hope is, as I recruit more nerve surgeons to work with me, that I can help filter out some of these that are pretty simple, median nerves in the forearms, pec minors, so that we share the load. And so then I'm more available to do the complex brachial plexus reconstruction. But when they come in, which they do weekly, I focus those, prioritize it, and people who may need to move off my schedule are the ones that aren't acute and problematic. But it is very difficult balance. Very, very difficult. Good.
Great. And thank you for your candor in answering that. It's a problem I've struggled with as well.
Yeah.
I'm just going to bring it to a close. I know you've got another teaching
Sorry.
immediately after this. So I just, on behalf of the GNF, I'd like to thank you for your ongoing commitment and sharing your expertise with us.
Okay.
And I'd like to thank Stephen for setting up the webinar and all of our attendees. And I look forward to seeing many of you at the next webinar. Thank you very much.
Thank you, Dom. So great to see you all. Thank you. Have a great day. We'll be in touch.
And you. Bye-bye.